Now, there can be some complications, and the possible reason for it is because the mesentery is very thickened and edematous, and because the patient is on steroids for the Crohn disease, so the healing is also impaired, and patient is malnourished, and patient is immunosuppressive because of the medical therapy. When you talk about the complications, you need to know the mechanism behind the development of, or the reason behind the development of these complications. So we talk about the complications, we talk about the ileitis, we talk about the proctitis, we talk about the anal abscesses and anal fistulas, and we talked about the other extraintestinal manifestations like amyloidosis and gallstones, and we talk about the primary sclerosing cholangitis. Now, we should know the reason behind the development of the complications because the patient is malnourished. Okay, so nutritional status is compromised because most of the time ileum is affected, and we know that the most of the absorption is in the ileum. The gallstones is because there is improper absorption of the bile salts because of the ileum. There can be associated anemia, and it's because of the vitamin B12 or folate deficiency, or because of the malabsorption. So remember, in chronically inflamed mucosa, that the mesentery is also thick and edematous, and we know that the blood supply is actually coming from the mesentery. So the process of the fibrosis and ulcerations would be there, and it would badly affect the gut, would not be healthy, and healing would be impaired because of the immunosuppressive therapy and because of the malnutrition. So these are actually the reasons for the complications, and you not only have to deal the complications, like you have to perform the surgery, but you have to give a proper nutritional diet. You put the patient on a total parenteral nutrition or enteral nutrition or NG feed. It entirely depends. Improve the immunosuppressive status of the patient properly, and good hydration and good nutrition status can actually prevent the complications. And if the complications are there and you're treating surgically, they can actually process of a healing should be proper, and the patient should be vulnerable especially after the surgery, for a healing of the process. And sometimes the patient, the sepsis, if there's a perforation, if there's a sepsis, so the sepsis can actually itself is a complication. And because of the sepsis, there are a number of other complications which can be developed. So you need to look for all these things. Now, there are some risk factors for intra-abdominal septic complications. So we should know the risk factors as well. And if the current high-dose steroid therapy is greater than or equal to 10 milligram, especially most of the time we give the prednisolone. And if the prednisolone is given for greater than, equal or greater than 4 weeks, continuously before the surgery, so the complication rate would be very higher. Now, if the patient is currently in a preoperative monoclonal antibodies, so we know that they're immunosuppressive. So they are actually, the immune mechanism is also affected by the use of the monoclonal antibodies. So that is one of the risk factors for the complication. Then if there's a preoperative significant weight loss that is greater than 10% premorbid weight, then it can be one of the risk factor for the complication. Or there's a pre-existing abdominal sepsis like abscess or fistula. And the albumin level, hyperproteinemia, the patient can actually develop hyperproteinemia because of the malabsorption. So the serum albumin is less than 32 grams per liter. So if these things are present in a patient, then these are actually the risk factors for the complication. So you not only have to deal with the complication, do the surgery, but you have to address all these complications, especially if the proper, you have to taper the steroids, and then you have to prepare the patient for the surgery. Remember the risk factors. If the current high dose of the steroid is greater than or equal to 10 milligram, prednisolone for greater than or equal to 10 for 4 weeks, before the surgery, or the patient is currently on a monoclonal antibody, or the patient is on an immunomodulatory agents, significant weight loss is greater than 10%, or there is a pre-existing sepsis, like in the form of the intracutaneous fistulas, or there is a abscess, like the perianal abscess, and the serum albumin level, the hypoproteinemia, and the patient is malnourished, then the risk of the complications would be, and the leakage of anastomosis, because what you do in the surgery most of the time, you are creating anastomosis, you're creating a primary anastomosis. But in case of these conditions, or there's a pre-abdominal sepsis, then most of the time there is a risk for the leakage. So you do not do the primary anastomosis, you do the ileostomy or you do the colostomy, and then you give a time of like a few weeks, 3 to 4 weeks, and then you just tell your patient to follow up with you, and then you plan a proper repair, or you do the proper you do a secondary anastomosis.